In this lecture, we're going to be talking about the cervical region. This lecture is going to be divided into two parts. The first part is we're going to learn how to diagnose the cervical vertebra, and then we're going to move into an important muscle that's also located in the neck, the sternocleidomastoid. So in the previous video, we just found out how to diagnose the thoracic spine. Why do we need to learn it again? So doing the same diagnostic pattern for the cervical spine will not work. It's going to be different. And it's different because there's no Fryette's laws. So when you're diagnosing the thoracic spine, you cannot use Fryette's laws. You have a completely different set. So before we go into that, we have to know what the primary motion of each cervical vertebra is. So your first area is C0, which is also known as the OA. The primary motion of this segment is flexion and extension. This will come into play when we start doing our diagnostics. So the next one is C1, which is also the AA. Primary motion here is rotation. Then you have C2 through 4. The primary motion is also rotation. And then you have the bottom cervical. You have C5 through C7. The primary motion here is going to be side bending. So how is the diagnostic pattern different? You're going to go through the same flow of assessing in neutral, assessing in flexion, and assessing in extension. But instead of looking at rotation, you're going to be looking at translation and side bending. And the rules that that's going to follow is going to be on this chart. So for C0 and C1, side bending and rotation occur in opposite directions. Meaning that if on an exam or in the clinic you're palpating the area and you notice that the patient can side bend to the left, you know that rotation is in the opposite direction, so they can rotate to the right. When you're assessing for this side bending, you're going to use what's called translation. So what is translation? Imagine that you're palpating the back side of the cervical spine. What you're going to do is you're going to use your fingers and push side to side on the cervical spine. So you're translating from one side to the other. So if I'm pushing from the right to the left, this is going to be left translation. But this is where people will get tripped up. You're doing left translation, but when you're making that motion, the cervical vertebra collapse to the right, and this induces right side bending. So if someone tells you that you can translate to the left, they're basically saying that you can side bend to the right. So that's how you translate. So going back to C2 and C7, side bending and rotation here are going to be different. They're going to rotate in the same direction. And how do you assess for this motion? It is the same, translation. So why is C1 written in red? It's a little bit different than the rest of them. Instead of trying to do translation, you're going to induce rotation. So what you're going to do is you're going to flex the spine to the level to 45 degrees, and then you are going to rotate the patient's head. This rotation is then going to tell you what direction you can and cannot rotate. And then using the same rule, you can tell that rotation and side bending occur in the opposite direction. So if they can rotate to the right, then they can side bend to the left. So let's go through a couple practice questions. So for this first one, you're in the exam, and they tell you that during flexion, the patient can side bend both directions normally. But during extension, the patient cannot side bend to the left. And let's say that these findings are for C4. So what's the diagnosis? So you follow the same rules. You always name it by what it can do. So looking back at the question, it can go into flexion normally, and it can side bend normally during flexion. So you can already say it's C4 flexed something. You know it's going to be rotated and side bent to some direction. They tell you that during extension, you cannot side bend to the left. But remember, you always have to name a dysfunction by what it can do. So if it cannot side bend to the left, that means that it can side bend to the right. So can side bend to the right. And then following our rules for rotation and side bending, C4, side bending and rotation are in the same direction. So you're going to be C4, flexed, rotated, right, side bent, right. So for the next example, they tell you that during flexion, you cannot translate to the left. This means that when they try and translate to the left, it doesn't want to go. But during extension, totally fine with translation. So translation is fine in both directions during extension. Let's say our findings are for C4. What's the diagnosis? Once again, same flowchart as always. You always name it by what it can do. So we're going to say C4. In extension, translation is normal, so it's an extended dysfunction. You know it's going to be rotated and side bent in some direction. So they tell you that during flexion, you cannot translate to the left. This means that you can translate to the right. But when you translate to the right, you have to remember that you are inducing left side bending. So it's a really important concept to understand which direction you're translating and what side bending direction that induces. So if you cannot translate to the left, that means that you can translate to the right, which means that you are inducing left side bending. So side bending to the left. And since it's C4, follow our chart, side bending and rotation are in the same direction. So our diagnosis is C4, extended, rotated left, side bent to the left. So now how do we treat this dysfunction? You can treat it many different ways like we talked about in the previous lectures. You can do muscle energy, you can do HVLA, you can even do counterstrain if you want to. It's all up to what you're comfortable with because there's no right answer for which one is better. So in this discussion, it'll be easier to give a demonstration on HVLA. So HVLA. So as we discussed previously, HVLA is a direct technique, meaning that we engage the restrictive barrier, or we engage what the patient cannot do. And it's also passive. Passive means that the patient does not assist during treatment. They're totally relaxed. The practitioner does everything for the patient. There are some contraindications to HVLA, which you need to be looking out for in your patients and on the exam. If they give you one of these contraindications, HVLA is not the right answer. You need to pick a different treatment style. So what are the contraindications? So you have osteoporosis. You can have fractures and metastatic cancer. So just think about it this way. Osteoporosis, fractures, and metastatic bone cancer can lead to a weakness in the vertebra. You don't want to be cracking weak vertebra. So don't do HVLA, you'll cause more damage than good. So what are some other contraindications? Rheumatoid arthritis and Down syndrome. So a contraindication to rheumatoid and Downs is going to be the same thing. For both of these diagnoses, you have an unstable transverse ligament. Because of this instability, you are not able to perform an HVLA treatment technique because you will cause harm. So if you see any of these, you are not allowed to treat the patient with HVLA. You have to pick something else. Easy way to remember this is that older individuals, like Granny, might have osteoporosis, fractures, cancer, maybe she's got rheumatoid. Don't be cracking Granny's neck. Choose something else. So there are two different types of HVLA treatments. You can have rotational HVLA and you can have side bending HVLA. Both of these treatment styles are very similar in that they're direct and passive, but the setup is just slightly different, and I'll go through an example with the cervical spine. So let's say that you have a diagnosis of C5 FRS right. So I'm saying that C5 can flex, can rotate to the right, and can side bend to the right. So how am I going to set this up for treatment? So what I'm going to do is I'm going to put the patient into the barrier because it's a direct treatment. So put them into the position that they cannot do. So I'm going to induce slight extension. It's a rotational HVLA technique, so I'm going to set them into the rotational barrier first. So we're going to rotate to the left. And then the last plane of motion is side bending. So I'm going to side bend to the left. The next part of the treatment is to get the patient to relax. You want them to take a couple deep breaths, get chilled out. It's easier to perform the HVLA technique when the patient is relaxed and they're not constricting their muscles, anticipating an HVLA thrust. So wait until they're relaxed, instruct the patient to breathe. So the next step is once that they are totally relaxed, you can then induce your HVLA force. Because this is a rotational HVLA treatment, your HVLA movement is going to be in rotation through the direct barrier. So you're going to HVLA, rotate, left. So you're going to perform the rotatory force through the barrier, which is to the left. After you perform the treatment, you are then going to passively return the patient to neutral, and then you're going to rescreen. So remember, after any treatment, whether it's HVLA, muscle energy, whatever, you have to return the patient to neutral, and you have to rescreen to see if your treatment worked. So now for side bending HVLA. Let's say once again our diagnosis is the same. So we'll say C5 FRS right. C5 can flex, can rotate to the right, and can side bend to the right. It's still a direct technique, so we're going to set them up into the barrier. So we're going to induce slight extension. It's a side bending treatment, so we're going to do side bending first. into the barrier. So we're going to side bend to the left. And this is where it's a little bit different for the cervical HVLA. Instead of rotating into the barrier, you're going to rotate into the freedom. So you're going to rotate right. The reason that you rotate right for this treatment is so that you can lock out the facets for everything above and below it for your treatment. So it really directs the treatment towards C5 and not anywhere else. So the important thing for you to see here is that rotation goes to the freedom for side bending, but it goes into the barrier for rotation. The rest of the steps are exactly the same. So you're going to have the patient relax. Once he's relaxed, you're going to do your HVLA force. Because it's a side bending HVLA treatment, you're going to induce your HVLA force through translation to the right. So this is where you have to remember, translating to the right means that you're inducing left side bending, and that is the barrier that you're going for, left side bending. So once you've done your HVLA thrust, you then return the patient back to neutral, and just like any other treatment, you always rescreen. So this is where we're going to break the lecture and stop talking about vertebra. And we're going to start talking about a very important muscle that's located in the neck, the SCM, the sternocleidomastoid. So the SCM has two origins. It has a sternal head, which originates on the manubrium. So right at the top of the sternum. And you have the clavicular head. Which originates on the medial 1/3 of the clavicle. So the sternal head originates on the manubrium. The clavicular head originates on the medial 1/3 of the clavicle. The attachment is going to be the mastoid process. So now that you know where the SCM originates and where it attaches or inserts, you can now get an idea of what the SCM does when it contracts. So if your origin and insertion are here, and you're contracting your muscle to bring the origin and the insertion closer together, you're inducing flexion, side bending towards, and rotating away. So as I'm making this motion, the origin and attachment are coming closer together. So what happens when the SCM is dysfunctional? Well, if you think about when the muscle is dysfunctional and it becomes hypertonic, it's going to shorten and it's going to try and stay very locked up in this position of what it can do. So if you know the anatomy, then you already know what happens during dysfunction. It does exactly what it does during normal motion. It just gets stuck that way. So the freedom for this dysfunction is going to be flexion, side bending towards and rotating away. The barrier of this dysfunction is going to be the opposite, or what it cannot do. So the barrier is extension, side bending away, rotating towards. Again, when the SCM is hypertonic, it wants to do this, it cannot do the opposite. So how do I do the treatment? So once again, this is going to be a recurring theme throughout the entire thing. You need to understand the concepts and then apply them to everything else. So if you're treating the SCM, you can do it many ways. You can do muscle energy, engage the barrier, ask the patient to isometrically move into the freedom and keep them going. But for this discussion, we're going to talk about the counter strain for this point. So we're going to do counter strain to the SCM. Since the SCM has two origins, it can have two different treatments. But we're going to talk about the main treatment position. This position is AC7. So the clavicular head insertion on the medial third of the clavicle is where AC7 is located. The sternal head is where AC8 is located. In this discussion, we're going to talk about AC7. So what's the treatment position? Remember, counter strain is always fold and hold. And to do that, you bring the origin and insertion closer together. So you do what the muscle can do. So you already know what the treatment setup is. You know that the muscle can flex, side bend toward, rotate away. So for counter strain, for the SCM, you're going to flex, side bend toward, rotate away. So this lecture was broken up into two different segments. We talked about how you can diagnose the cervical vertebra and that there's no Friet's laws in this area. You have to follow a different chart. We talked about how you induce translation and how it relates to side bending. We did some practice questions, gave some examples of HVLA and definitely some contraindications. And then we switched gears, talked about the sternocleidomastoid and related it to counter strain. And that's OMM for the cervical spine.